Hello, so my name's Hannah Bennett. I am one of the pain medicine trainees at the North Queensland Persistent Pain Management Service. My background is that I am a GP rural generalist for the last couple of years and have taken a bit of a turn into doing pain medicine training. And I have one of my colleagues, Dr. Steve Gilbert, who introduced himself as well.
Hi, I'm Steve Gilbert. I'm an anaesthetist who have trained in pain medicine, working with the North Queensland Persistent Pain Service for 4 years now.
Right. So today we're talking about chronic or persistent pain and trying to turn those difficult situations into something a little bit more hopeful. And as all of you will know, chronic pain is a really big problem and it's a significant cause of disability and costs Australia a lot, indirectly and directly. And it's a really complex and difficult situation to deal with, particularly in rural and remote areas where you don't have as much access to allied health and potentially pain specialist clinics. And, you know, these are complex and difficult patients. They present a lot. Treating them with the way we usually do doesn't really work all that well. And in fact, some of the medications that we prescribe to help have actually become much more of a problem with significant adverse effects and mortality. And, you know, in primary care, you only have 10 minutes to deal with that really complicated situation. And on top of that, a lot of our training as health professionals really focuses on the more acute sort of biomedical causes of pain. And we know that with persistent pain, those types of treatments don't work. Pain is persisting despite, you know, any tissue healing or tissue has already healed. So our aim today is to help you understand and be able to explain pain, feel comfortable assessing it, be aware of some of the limits of biomedical treatment. We'll talk a bit about how to approach some problems with treatments not working and potentially with your patient's behaviour, and link you in with some resources for you and your patients.
Thanks, Hannah. Well, as Hannah said, the thing that we get taught most about in medical school is nociceptive pain. That's due to tissue damage, so due to an injury, a broken leg, a tumour growing. And so that's really where a lot of our training is focused. Neuropathic pain gets lots of press, partly because of treatments that are available for neuropathic pain and promotion of those. But in fact, if you look at all the people with persistent pain, it's only about 5 to 10% of people who have neuropathic pain due to damage of the nervous system. And the majority of people that we see in the pain clinic and you'll see in primary care have got nociplastic pain. So most people won't have heard of that. That's also been called in the past central sensitization, and it's due to overactivity or wind up. The dial's turned up in the nervous system. So there's lots of signaling and nervous system activity, which is creating pain, even when there's not any significant damage to the tissues. So this is real pain. It's not imaginary or psychological. There are lots of ways of describing chronic or persistent pain. For most people, perhaps the best way is to say that the pain carries on long after any tissue healing or an injury would have been expected to be finished. And this is commonly defined as 3 months or 12 weeks. In this situation, the pain is not useful. Indeed, it stops people doing things that they used to do and causes suffering and disability. As Hannah mentioned, it's very common. Around 1 in 5 people have continuous pain, and some are a lot worse than others. Around about 6% of the population have really severe disabling persistent pain. And of course, it's really worrying to the patient. Patients feel that there's some damage going on, even if nothing can be found to explain the pain through seeing doctors, specialists, or doing tests. The nervous system just carries on in the same way as if something was damaged. So this can be confusing for us as well. As a patient, doctors, we're trained in diagnosing and treating diseases. If your patient has a chronic pain without an obvious cause, if they have been told that surgery wouldn't be useful, they can end up feeling that doctors can't help or understand the pain, and they get the feeling that they just have to put up with it, or they've been told that it's just in their head, or otherwise they can get the feeling that they can only manage the pain with medication, like strong analgesia. So this sort of slideshow aims to make sense of chronic pain in a way that you can understand and explain to your patients which can be a great first step in thinking about how to manage it. So if we take the example of back pain, doctors and patients are often thinking in terms of how much damage there is. We can do x-rays and look at MRI scans and find quite a lot of changes as we get older. But these investigations, in fact, aren't really very much use in the investigation of back pain. So, for instance, this X-ray shows lots of changes, osteophytes and scoliosis, and we get a report of severe degeneration. But interestingly, this is an X-ray of an 80-year-old lady who'd never had any back pain in her life. She had the X-ray for a bowel obstruction. So we should know that age-related changes in X-rays are a natural part of life and don't necessarily cause any problems. If we're tied into the pain means damage way of thinking, though, we can get into pinning the damage down to degenerative changes or arthritis. And we should try and reframe this for the patient as natural age-related changes. The same applies to injuries or operations. People can have the same operation and have much different amounts of pain. This is all to do with the fact that pain is a process in the nervous system, and the amount of pain that you have is not necessarily related to the amount of damage that there is. It's to do with how much signalling is going on. This often causes confusion with MRI scans as well. Most people will have bulging discs, and even if they don't have any pain. The most important thing to think about is when looking at the spine is there enough space for the spinal cord and the nerves? In this MRI, there's a small disc bulge. The report would say degenerative disc bulge or disease. There's plenty of space for the nerves. You can see the spinal fluid, which is white all around the black nerves. So the reason for getting an MRI scan is to see if there's any pressure on the nerves. Sometimes a neurosurgeon can make more space. Even if the disc is touching a nerve, most people will get better by themselves rather than needing an operation. And neurosurgery doesn't seem to help with back pain. So we see reports of disc degeneration in more than 50% of people in their 30s who don't have any pain. It's really important to emphasize to the patient we only need to do a scan if we found a neurological abnormality. It might be helped by a neurosurgical approach. Most patients will not want to have surgery, and indeed in most cases sciatica or nerve root irritation will get better by themselves without needing surgery. But this can take quite a long time. So giving the patient 6 weeks or 3 months might be unrealistic. It might be 1 or 2 years until things get better. At the same time, it's important to screen the patient for red flags, the indicators that there's some possibility of underlying disease. And then it's a case of taking a careful history, examining the patient, and thinking about tests for inflammation or infection or underlying sinister causes of back pain. So if we go on, Hannah, then the next slide shows where I find the problem with most patients with back pain. They usually have very tender trigger points in the muscles where they join into the back of the pelvis. So trigger points are lumps in the muscle which are intensely contracted all the time. This produces an aching and stabbing and burning pain with spasms and stiffness, and the pain may travel up the back into the ribs or down the leg, but not in the dermatomal pattern. So the big problems with trigger points are that, first of all, we don't learn about musculoskeletal medicine at medical school. We concentrate on the bones and the disc. Secondly, the pain isn't signaling any damage. Pressing very gently on the trigger point causes lots of pain, even though you haven't injured the patient, or the pain can flare up for no reason, just sitting in one place. And medication isn't any use for this sort of pain. People can be taking lots of strong analgesia, and when you press on their trigger points, they're still experiencing severe pain. So often with pain that goes on and on, people develop problems with their sleep. They feel worn out during the day and they can't concentrate. And no one can explain why the pain is there, or they get conflicting opinions, and treatments haven't been any use to the patient. So they can often end up quite confused and angry and feel, why is it happening to me? And anxiety and depression often go together with pain, but this, I think, is a natural reaction to the continuous suffering, the fact that no one's making them any better, and the change in their quality of their lives. So this can lead to confusion and difficulty understanding pain, and relatives and friends might see patients sometimes able to do something, and then other times having severe pain, which ruins the things that they want to do together as a family. People are taking lots of painkillers and still having terrible pain, and they get the feeling that the doctors don't believe how much pain they're suffering. And the problem is that we're stuck with this damage related to how much pain there is paradigm. So if we think about the social way that this is developed, normally if we're injured, we would expect to be able to see some evidence of that. But if I think about when we were evolving as a species, and I was to say when we were going to go out hunting and gathering, oh, I've got a bit of back pain today, I don't think I'll come out hunting and gathering with you, then my fellow cave people would say, yeah, how bad is it really? And that's still going on today. So the problem is that the pain is very much to do with the activity in the nervous system, as we've been saying. And what we need to do is to find a way of helping patients to understand that this doesn't mean that it's all in your head. So one of the best ways I've found to explain this is to look at the way your brain deals with something else, like vision, for instance. This is a really straightforward process. There's not any psychology involved. So if we're looking at this little chessboard with the green cylinder on it, Hannah, which of the squares looks darker, A or B?
A looks darker in this picture.
Yeah, that's fairly straightforward, isn't it? There's more light coming out of B, which makes it look lighter in the wee picture at the back of your brain. But if we rub out the rest of the picture, we can see that something really surprising happens. These squares are exactly the same colour because it's an optical illusion. If we put the rest of the picture back in, now we know that I was tricking you, that the squares are exactly the same colour, but we can't see them being the same colour. So if we put this grey band across the picture, we can see that A and B are exactly the same colour. But if we take the clue away, B goes back to being light again. So if we try going back and forward through the slides, then we can see, it's changing the colour. It's really confusing. Now, this isn't a psychological or imaginary process. It's something our brain's doing for us. So in the case of vision, it's looking at that big shadow going from the green cylinder over the chessboard and those squares round about B, which are quite a bit darker, and it's going, B must be lighter than I'm seeing it. It makes it really lighter in the picture in your brain. So the way of helping patients to understand about this is that in pain, we can see the squares being the same colour with the clue being in, then that's kind of like the conscious bit of your brain, which is trying to figure out what's the damage, what's it due to, what should I do about it. Whereas this optical illusion, where the square B looks lighter than it actually is the bit of your brain that's trying to figure things out for you, the predictive bit of your brain, or the unconscious, which is saying, why is this going on? How dangerous is it? Why can't things just relax? And if we try and use willpower to switch that brain process off, it doesn't make any difference at all. So if we look at the way that the nervous system works, then we've got our conscious bit of the brain, which is figuring out logically what should we do about the pain, and do I need tests, do I need another specialist opinion, do I need a different medication? And then we've got the affective part of the brain, where the fight or flight reaction, autonomic system responses, and the predictive unconscious processes that go on in our brain are housed. And you notice how the fear and anxiety and depression and sleep are all in this limbic system part of the brain, as well as a lot of persistent pain processing. And it really illustrates how these things are connected. So what we have is the conscious bit of our brain trying to beat the pain, and then the predictive unconscious bit of our brain going, how dangerous is it really? sending messages back down the nervous system to make all the muscles tighten up and to increase the amount of feedback in the nervous system. So we're best to check for biological organic cause for the pain, but to be aware that what we see on the X-ray or the scan might not be directly related to whether there's pain or not. It's a complex phenomenon that's produced in the brain, and we can call it a biopsychosocial condition because there's biological stuff going on in the nerves, there's psychological stuff, which is to do with the natural responses in the limbic system, the anxiety, depression, fear, and then there are social things which are to do with, a lot to do with the medical system and how much we concentrate on that biological part, and whether we take medications, whether we become disabled, whether we go through treatment. So if we go on to assessment, we don't have very much time to talk about assessment in this short talk, but basically we're looking to get an idea of what the pain is like, whether there are any worrying features that might lead us to investigate further, which are the red flags, how the patient feels about the pain and what they think it's due to, and whether there are any yellow flags, which are the psychosocial factors that predict greater likelihood of chronicity and disability. There's a great healthcare professional section in the ACI pain website, which takes you through assessment and developing a management plan. And there's also the steps through how to manage opioids there. Now, one of the biggest problems with pain management has been the adoption of the World Health Organization pain ladder for the treatment of non-malignant pain. There are many societal reasons for this. Influential researchers said it would be safe and effective. Drug companies have promoted opioids, and patient groups and pain specialists have campaigned for pain as a fifth vital sign, or pain as a disease, or to stop the pain. Unfortunately, though, we found that strong opioids are not effective for persistent pain. There's no difference in pain relief with back, hip, or knee pain, as shown in the SPACE study, which is detailed on the in the notes on this slide in JAMA 2018. And we have to note that the World Health Organization guidelines are for cancer pain, not for non-malignant pain. In the Lancet Back Pain papers of 2018, there's a really good summary of what's gone wrong with the treatment of back pain. We've known that movement and activity are the most effective treatments for more than 30 years, but we keep prescribing more medication, doing more tests, more investigations, and sending patients for more surgery. In addition, we have the societal message that you better be careful with your back. If you do lift something too heavy, you might cause damage, and that there's a whole issue of work cover and disability, which is a disincentive to the patient ever getting any better. So this graph is pretty self-explanatory. The number of people coming to serious harm from their prescriptions, which are taken as prescribed, is increasing. So more than 1,000 people in Australia a year are dying from their prescribed opiates, which is much more than the number of people that are killed in car accidents or from taking illegal drugs. Canna.
So moving on to looking a bit about, what are, how can we work with these sort of, and there's a number of problem behaviours that we probably come to mind when we're thinking about the patient. They might have an overwhelming focus on medication. They're really resistant to looking at any other avenues of therapy despite adverse. There's all of the, typical aberrant drug use that you might think of, but maybe just something more simple. They're presenting all the time. They want that fix. They're just sort of difficult to deal with. We often feel really helpless and overwhelmed by these. I think that there's a few reasons for that. I think it's things about the patient themselves, the system, and us as well. We talked about a few things about the patient, potentially desperate, demanding. About health professionals, they're really quite exasperated and they want us to fix it. The system doesn't help us in primary care. It's set up for short 10-minute appointments. It's really difficult to deal with in that time. Perhaps they see someone else, they've for a script. The waiting list for the specialist pain service is really long. You don't have access to my health and other specialists. And for ourselves, sometimes we feel like we don't really know how to help them. Maybe we're not confident in our knowledge about chronic pain, we're uncomfortable with prescribing, we don't know how the patient's going to respond if we challenge their current treatment. And it's pretty emotionally draining. So we're going to look at some strategies of how we can turn it around and give resources that you can use as well. So this, you might like to use the Pain Navigator tool. The management of chronic pain in a 10 to 15 minute can seem pretty daunting, particularly for a new patient or even someone that you've been managing for years and years. It's really important to set a sort of a strategy, I guess, for management. And it might be asking the patient to specifically book a long appointment to talk about making a strategy, and that where you can address any other acute or chronic issues at this appointment. This form can be helpful for the patient to take away and bring back to the appointment. Tick some things that are pertinent to them, help sort of guide the conversation. Sort of that first step in them realizing different parts of their life that pain affects. For a new patient in an hour, I would spend over an hour doing a hearing examination. I know that this is a luxury compared to situation in primary care, but it's maybe setting out that over 4 appointments you do a full assessment and work through all of those things. And I think on the ground in primary care, starting that pain education is a really important thing. Managing chronic pain is really different from acute, but all of our experience, mostly as patients, is dealing with, what the management for acute pain is, and so it makes sense they think that that's how it should be managed. So particularly if there's long waits for your pain service, starting talking with your patient, maybe changing that way of thinking is a really important step. So medications is a really common question that, get referrals about or calls from other, doctors. And unfortunately, medication just isn't that effective in treating chronic pain. In fact, there's really not a lot of benefit from them at all. I mean, it can be a really tricky space to manage that with the patient and navigate that. But I think some really important questions to ask yourself as the clinician looking after them and when you're dealing with medications is this rational polypharmacy? Is the type of medication appropriate? Are there side effects? Are there complications? Can you confirm that what they're on are correct? Talking to your drug of dependence unit, the previous prescriber, what's your comfort level with what they're on? A dose of equivalent to an oral morphine equivalent of 60 milligrams per day, there's really not a lot of benefit in that. Is their pain and function better with the opioid? That's the real key. What are their pain scores? Are they doing well with the medication? And is the patient at risk if I maintain the same prescription? For any patient that you prescribe opioids with, it's really important to have an opioid agreement and contract in place. Most states have their own version, but the ACI website that Steve mentioned earlier has really good guidance on that and with some key features. And, it goes through all the different things, particularly, establishing function and activity-based goals, and also reasons for, that tapered termination will be commenced if those treatment goals aren't met, if there's adverse outcomes, if there's misuse, if they're not coming back for reviews. So opioids, in themselves, when you're caring for someone with opioids, there's a few different options, including tapering and cessation, rotating or continuing. I think before you do any changes, be clear with the patient that the reason you're doing this is actually they will feel better with these changes. Their pain will be no different. It might actually be better, and they will feel a lot better and be able to do a lot more. There's a lot more detail in the notes section of the PowerPoint access to about this, that you can have a bit of read of more of the specifics. So I think the key thing is that conversation, really engaging in motivational interviewing, so that the patient, I guess, trusts you and believes, that then what you're doing is actually what's going to help them. You're non-judgmental, and we're really moving towards that active, safe self-management. There are heaps of different resources you can direct patients to. Health New South Wales, that ACR website has great videos for adults, kids, resources for Indigenous Australians. There's the Pain Navigator concern tool that we spoke about. The Pain Toolkit is a resource that has a number of different tools to manage chronic pain that patients can work through. There's online courses about chronic pain and learning ways to manage it through MindSpot and This Way Up. And Explain Pain is great book that is useful for both patients and clinicians, just to kind of understand the changes in chronic pain, why it happens, and how we can, I guess, manage it. There's a few links there. And for yourselves as health professionals, the Faculty of Pain has a better pain management program that you can sign up to do. Lancet paper, opioid calculator, the Faculty of Pain has a lot of different position statements. There's a heap of resources from the RACGP as well. If you want to find all these resources in one place, our Townsville Chronic Pain Support Group website, which Steve has put together, is a really great place to go to find everything all there, and there's a few links there.
So the pain toolkit is one of the simplest ways I've found of helping patients to start down a rehabilitation route, really thinking about how can I start dealing with the issues in the nervous system that have led me to have so much trouble with pain, so much disability and so much suffering. It's written by Pete Moore, who's a normal person, and I put it to patients that he explains what he'd learned from doing a pain management program after he had 10 years of treatment for his back pain, where he had lots of investigations, lots of treatment that didn't really help him. And that was 20 years ago. He did the pain management program, and now he's able to do what he wants. He's doing what he wants in life rather than the pain controlling his life. So it's available online in many different languages, and I usually print out a copy for the patient. I give them a quick run through what's in the toolkit and ask them to have a look at it at home with their partner, and think about the 3 tools in the toolkit they really want to get started with, to write them in the middle of the booklet, and to bring that booklet back to the next appointment. So one thing I found really most helpful is to have a look at the way that the pain works for the patient, and to think about the biomedical side of things. We know that medication's got a limited effect on suppressing increased signaling. Opioids mainly work in the alarm system and the limbic system, making things feel safer, but this isn't a long-term solution. Tricyclics, antidepressants might reduce descending facilitation, those messages coming back down the nervous system and increasing sensitivity and tightening. And injections, procedures, they can interrupt the input, but they're pretty temporary. And if we hope that we're going to switch the nervous system off and then it's going to come back on normal, then I think sometimes things we're a bit over optimistic. So psychosocial, if we can understand why the nervous system has become so active, it can really help us to start de-threatening the pain, and thinking about how we can start taking charge, taking that pain toolkit rehabilitation approach. I generally ask people to think about relaxation and mindfulness, and really putting some time into that. You don't just do it once or twice and say, oh, it didn't work. You have to be really persistent and look for long-term gains. And then one of the most important things that I think patients say makes a big difference to them being able to manage their pain is the boom-bust cycle, and managing that with pacing. So I say to patients, if you look at the way that pain normally is, there's sometimes where it's not so bad, and then sometimes when it's really bad. And that's the normal pattern with persistent or chronic pain, that it goes up and down. If you've got something that's getting better after an injury, then we expect it to go down and down and down. Or if you had something that was due to an underlying disease, they would expect it to go up and up and up. But persistent pain goes up and down. Now, the reason for that is that when the pain goes up, remember the diagram in the nervous system, we've got lots more feedback, lots more messages going down the nervous system into the spinal cord, and increasing wind up and sensitivity and muscle tightening. Now, if we think about it with the patient, what is it makes the pain go up? Is it sitting in the car when you're driving for an hour, or is it walking 100 yards? These are things that don't necessarily cause any damage, but they cause lots more signaling, which is real pain. Then if you rest or take your medication and the pain might feel better, that isn't necessarily good. It's not dealing with the underlying problem. It's just like putting a sticking plaster over it. not a long-term solution. And you might end up being less confident, less fit, and depending on taking medication. So the way to try and help patients to think about pacing is to start with, where am I definitely okay? So if you're sitting for an hour and that's too much, what about half an hour? Nah, I'll still be sore. What about a quarter of an hour? Might be okay. What about 5 minutes? I'd definitely be okay. So you start where you're definitely all right, where you're really confident about your ability to manage, and then you stretch the edges of what you're confident with. So it's a way of retraining the nervous system. Remember, with the optical illusion, we can't decide about these predictive or unconscious processes. We have to find ways of getting under the radar to start being able to do more and get back to more normal function. Now, another way of finding out more about persistent pain management is a project that we're starting on, which is partly to do with the problem that pain services are so limited in their ability to see everybody with persistent pain. Everybody with persistent pain is in the community and coming to see you in general practice. And so a way of finding out what we know about pain, getting to understand more about how to direct patients towards self-management and psychosocial management, is this Project ECHO. It's an online set of educational sessions where there's a little bit of didactic teaching for only 10 minutes of session, and all of the rest of the session is to do with case discussion and the input of a multidisciplinary team. And it's a scenario where everybody learns, so we can learn from you as well as you learning from us. There's a SurveyMonkey link at the bottom of the slide there. Explain Pain, I think, is a really fantastic way of patients and doctors understanding some of this new understanding we have about neurophysiology. It's all the stuff that we learned in the last 20 years about how the nervous system works in pain, and in really straightforward language, so very accessible for patients. And then to find out anything more about persistent pain management, please visit our website, North Queensland Persistent Pain Management Service. This is the short link, bit.ly/NQ-Pain. And there you'll find the links to the Townsville Chronic Pain Support Group website, information for patients, all the other links that we've been talking about in the talk today. So I think that's about all we've got to say. Hannah, thanks very much for joining us today.
Thank you.
And thanks very much for watching. We'll post a PowerPoint version of this talk on the Rural Health website, and also on the North Queensland Persistent Pain Management website.